All right, so having talked about the skin, we need to talk about the skeletal system, bones and cartilage. So, oh, sorry. So, bone, cartilage are connective tissues. We've talked about loose connective tissue and dense connective tissue. So now we're over here. There is a lot of difference between the tissues themselves, but there's also a lot of similarities. I mean, they are all connective tissues, so we're going to have cells and a bunch of extracellular matrix. The cells that sort of secrete the extracellular matrix for connective tissue proper, called fibroblasts. For bone, those are osteoblasts, and for cartilage, that's chondroblasts. Anytime you see that osteo, that always refers to bone. Chondro always refers to cartilage. The osteocyte then is the sort of mature form of the osteoblast. It's not actively secreting the matrix, its job is just to maintain. And it's sort of a similar issue with the chondrocyte. Now, macrophages are part of the immune system. They phagocytize other cells. Osteoclasts dissolve bone, and chondroclasts dissolve cartilage. Outside those cells, we have mostly collagen. Now, connective tissue proper and cartilage can have elastic fibers. The ground substance, the sort of tissue gel, is sort of a thing called glycosaminoglycan, which is a amino carbohydrate thing. The only difference here is that with bone, it's calcified. The glycoprotein, the proteins found outside the cell, fibronectin, osteonectin, or chondronectin. Connective tissue proper is not wrapped in connective tissue, but it is. But both bone and cartilage are wrapped in connective tissue proper. Bone on the outside has the periosteum, and on the inside has the endosteum. And on the outside of cartilage, we find the perichondrium. Let's begin by looking at cartilage. Cartilage is kind of a gel. It's made for resilience. Cartilage takes a beating. More so than other tissues, and it can bounce back to its original shape. It's very solid. And when I say solid, I mean there's no porous to it. It's not porous at all. It's really solid. In fact, it's so solid that there's not enough room for blood vessels to grow into it. Blood vessels grow around it. So the cells inside the cartilage have to rely on diffusion. Stuff has to leave the bloodstream and diffuse in the cartilage because the blood vessels don't go directly through it. But because it is avascular, it's allowed to be very solid, and because it's very solid, it can take a beating. Now, the cost of being avascular is that it heals really, really slowly, and it's limited in thickness because cells rely on diffusion for nutrition. If the cartilage gets too thick, the cells in the middle die. And because there aren't enough nutrients and oxygen being delivered to these cells, repair is really, really slow. Cartilage is surrounded by connective tissue we call the perichondrium, and this is where we find the cells that are going to be secreting new layers of cartilage. This is also where we find the blood vessels that are going to be delivering nutrients. Cartilage can grow in two ways. It can grow from the inside out because it's not calcified like bone. It can push out from the inside. That's called interstitial growth. And can also grow, much like bone, by adding rings around the outside. That's called appositional growth. Chondroblasts are the immature cartilage cells that are in the perichondrium on the outside of cartilage. Their job is to add new layers of cartilage. That's appositional growth. Eventually what happens is they're secreting cartilage all the way around them. And they sort of get caught in that cartilage so that they can't do that anymore, and then they become chondrocytes. Chondrocytes are the mature cartilage cells inside the cartilage. Now, they can undergo mitosis, and if they undergo mitosis, then they're going to push out from the middle, and that's interstitial growth. Chondroclasts are cells that dissolve cartilage. So here are our chondroblasts, and you can see them laying down this new sort of dark purple cartilage there. And as new cells get added out here, the older cells are here and they're trapped in the middle, and they're the chondrocytes. This is appositional growth. We're adding new rings around the outside. Cartilage can also grow from the inside out. Here we see mitosis of those chondrocytes, and it's adding new matrix and it's pushing out. All right. Moving right along. Three different types of cartilage tissue. Hyaline cartilage. Hyaline cartilage is very smooth. It's glass-like. It's the most common type of cartilage, and its job is to provide a smooth surface for movement. It reduces friction. So we find it in all the articular surfaces, the movable joints. We find it between the ribs and the sternum. And this is where long bones begin. We'll talk about their role as a precursor to long bones and bone formation later. Here we see hyaline cartilage. Notice this extracellular matrix is very smooth. It's uninterrupted by any sort of fibers. Elastic cartilage is stretchy. It's like elastic, right? You stretch it out and it bounces back to its original shape. We find this in the outer ear and in the throat. And here we see all these elastic fibers out here in the matrix, so it can bounce back. If you have pierced ears and pierced down in the earlobe, you're just going through skin and connective tissue. Pierce the ears up in the cartilage, and we can see how cartilage doesn't heal, or it heals very slowly. It's much longer for cartilage to repair itself than it does epithelial tissue. Fibrocartilage is the third type of cartilage. It's a shock absorber. It looks like dense regular connective tissue because it's got these big bundles of collagen fibers, and its job is to support your weight. We find that in between the vertebrae, in between the femur and the tibia, at the meniscus of the knee, and at the pubic symphysis, in between the two pubic bones. So there's fibrocartilage, and you can see those collagen fibers in there. Now there's a term here, lacuna. The lacuna is the space around the cell. There's the actual cell, and then you have the space around it. That's called the lacuna. It's the little space where the cell lives in this connective tissue. So here again are places where we find cartilage. So to review, hyaline cartilage, elastic cartilage, fibrocartilage. Moving right along. So what do bones do? Well, obviously they hold you up and let you move and that sort of thing. They protect your brain and your heart. But they also store calcium and phosphorus. In fact, 99% of the calcium that is currently in your body is stored in the bones. And you have to be able to borrow that calcium on occasion so that you don't die. Blood is made in bone marrow. Red bone, there's two types of bone marrow, red marrow and yellow marrow. Red bone marrow makes blood. Yellow marrow is triglyceride or energy storage. And if we're including all the bones and not just the skeletal system, there are also three tiny little bones in the middle ear that allow you to hear. Bones can be classified, bones of the skeleton, I should say, can be classified by their location with the axial skeleton, which is the skull, the vertebrae, and rib cage. And we have the appendicular skeleton, arms, legs. Bones are classified by their shape. Long bones are self-explanatory, as are short bones. Flat bones, still self-explanatory. Irregular bones, this is the best naming scheme we've got. All right. If we cut open the bone, inside what you'll see is different tissue. On the outside of the bone, we have compact bone. Compact bone is the really hard, uniform surface of the bone. It's what provides the support, the strength of the skeleton. On the inside of that, we have this sort of meshwork of bone that's formed. That's called spongy bone. Spongy bone is in the epiphyses, or the ends of the long bones. It's in the whole cavity of the skull, in between the two layers of skull bones. And this is really where blood cells are going to be coming from, or in these little spaces there. This is also where we're going to borrow calcium from later. So let's look at sort of the generalized bone. Here's a long bone. The center is called the diaphysis. This is sort of the shaft in the middle. It's going to be wrapped around the hollow cavity that should be full of bone marrow. At the end of the diaphysis, here and here. Sorry, man. There and there. Those are the epiphyses, where the bone's going to articulate with something else. The outside of bone is surrounded by a tissue called the periosteum. It's a double layer membrane. Some of the fibers in this membrane will actually grow into the surface of the bone to keep that tissue attached to the bone. These are called perforating fibers. This is also what's going to hold tendons, ligaments to the bone. Just another few of those Sharpies are perforating fibers and this hollow marrow cavity. And while the periosteum wraps around that here, in between the bone itself and bone marrow, here in yellow, we have another tissue called the endosteum. The endosteum has cells that are going to dissolve bone and cells that are going to deposit bone. So we see osteocytes and osteoclasts. In kids and adolescents, you'll see a blank space here on an X-ray. It'll just be a blank line. It's called the epiphyseal plate, the growth plate. Now, in an adult, that's fused, and you won't be able to see that sort of hollow window there. But in children, there's a little, on an X-ray anyway, it'll be a black line. And that tells you that it's a kid. A lot of times in lab, when we pass out bones, people will ask me that question: is this a kid bone? Does this come from a kid? Because they are fairly small. But the bones we have in lab didn't come from a kid because they're one piece. Kid bones are joined by cartilage right here. So after the skeleton's prepared and all the organic tissue is removed, these two pieces are separate. They're joined together by cartilage at the epiphyseal plate. So kid bones have to be glued back together. You ever got an X-ray when you were a teenager and they're like, "You're done growing"? That's what they were looking at. They're like, "You're still growing." That's what they were looking at as well, to see if that growth plate had sealed. Now, flat bones have a different sort of structure. You have compact bone, spongy bone, compact bone. Crunchy on the outside, chewy on the inside. Here in the skull, this spongy bone is called diploe. Now, if you watch auto racing, and many forms of auto racing now, the tracks have what are called soft walls. And a soft wall, what you get is concrete, styrofoam, concrete, so that when your car hits the wall at 200 miles an hour, that styrofoam disintegrates. But in doing so, it disperses the force of impact. This is also the function of that diploe. If you get hit in the head, you may crack that compact bone. You may even crush that diploe, but it's arranged in such a way that the force is dispersed and it doesn't damage the inner bone or the brain beneath it. It's like a built-in helmet. Here's a great section of a humerus, and you can see the blood vessels, so many blood vessels. Bone is very vascular tissue. Cartilage is avascular, but bone, there's lots of blood vessels in bone. With the periosteum on the outside, endosteum on the inside. Lots of blood vessels going through there. So bone. Bone is very hard. You've seen bones. Very rigid. Because that extracellular matrix gets calcified. The nutrients can't diffuse through that calcification. So they have to travel there some way. So blood vessels grow into the bone. Where cartilage is very solid, bone is very porous. There's tons of little tiny holes in bone for blood vessels to go through. So it's very vascular. Luckily, that means that it also heals really well. Growth of bones will be appositional. You don't get growth on the inside. It's calcified, it's hard, you can't push out. So let's look at both compact bone and spongy bone. Compact bone, the unit of compact bone is called the osteon. And it consists of these little circles. These are called concentric lamellae or layers. In the middle of those concentric lamellae, we have two blood vessels, a vein and an artery. The blood vessels here, and then these rings around it, and big rings around that. Each one of these things is an osteon, so a central canal, the thing in the middle, and then the surrounding layers, those are osteons. This creates a really, really structurally sound bone. Here in between those little rings, those little brown spots, are the actual osteocytes. Now, like I said, there's no blood. You'll notice there's little red and blue blood vessels going out there through those little bitty spaces. Instead, nutrients are coming up through these blood vessels and then going out through those tiny little canals. Those tiny little canals are called canaliculi. They connect the cells to each other. All right, so there's our lacuna again, canaliculi. There's another view of that. Here it is under microscope. We can see those little lacunae, and we can see the little canaliculi connecting them to each other so that nutrients can flow from cell to cell. Now, that's compact bone. Spongy bone, we don't get so much organization. These little spikes of bone through here, little spicules of bone, those are called trabeculae. And while they look haphazard, they're also lined up in such a way that force is dispersed through spongy bone. And in fact, it's spongy bone's job to do that. There's no lamellae. You'll see there's no concentricness here. The layers are just sort of randomly laid out. There's no canaliculi. There are little canals. Sorry. Okay. There's no little capillaries going through here. There's no blood vessel or central canal in here. Now, there's little canaliculi that connect them, but they open up out here so that nutrients. Oh, my little laser pointer thing is not working. I apologize. So nutrients come in through those tiny little holes and then in through the cells, through these little tiny irregular layers. Bone is interesting because it's a composite. It's made up of different substances with different physical properties. We have an organic part of bone and an inorganic part of bone, so that it's really strong, but it's also flexible. It's strong without being brittle. Here's the makeup of what the tissue is made out of. The organic part of bone is, of course, the cells, and then what we call the osteoid. This is the organic bone matrix. The osteoid is mostly collagen. Now, collagen is flexible. So when you see organic bone, I need you to associate the organic part of bone with collagen, because that's what it is mostly. You need to associate organic part of bone with collagen and collagen with flexibility. So, organic, collagen, collagen flexibility. The inorganic part of bone is mostly a calcium salt, it's hydroxyapatite. It's a calcium phosphate sort of thing. And it's what makes bone hard. So you need to associate inorganic with hydroxyapatite and that with the hardness of bone. This balance between being flexible and being hard is important. It allows the bones to be really strong, but without being brittle. If I take away the organic part of bone, if I take away the collagen, if I screw the collagen up, then I lose flexibility. We actually have a disease here. Osteogenesis imperfecta. Or brittle bone disease. In patients that have osteogenesis imperfecta, the collagen fibers aren't formed correctly, so the bones are brittle. So I know what you're thinking right now, like that movie Unbreakable. Not really. People with osteogenesis imperfecta don't look like Samuel L. Jackson. If we have time, we'll look at that later. On the opposite end of that, if we lose the hardness of bone, then we're just left with that. We have a childhood disease, rickets. Rickets is a lack of bone mineralization. So the hardness of bone doesn't form. So the bones become overly flexible and they bend under your weight. Again, we'll look at that later. Cells of the bones, osteoblasts and osteogenic cells. Osteogenic cells are stem cells. Osteoblasts lay down that organic bone matrix. Osteocytes are the mature bone cells. Their job is just to maintain. This is a great picture. You can see those osteocytes and those tiny little canaliculi connecting them. Osteoclasts are the cells that break down bone. All right, so osteoclasts, things you need to know. These are multinucleate. More than one nucleus, there's nucleus. You get the point. They are phagocytic cells. They dissolve the bone matrix. They secrete an acid and an enzyme to digest that bone and break it down. More on that later. Bones form through a process called osteogenesis or ossification. Starts about the second month of development. Bones form in either through intramembranous ossification or endochondral ossification. Intramembranous is how skull bones form, and endochondral ossification is how long bones form. We'll look at intramembranous ossification first. In intramembranous ossification, you start with a connective tissue membrane. Stem cells in that connective tissue turn into osteoblast, and bam, we're laying down bone. So here's our osteoblast, and I start secreting that bone matrix. Now that they're trapped there in the middle, they're osteocytes. Blood vessels will move in that area to try to take care of that. And they get bone laid around them. And so now they're trapped in that developing bone. We call this woven bone because the bone weaves around those blood vessels and traps them in place. Over time, the bone matrix gets remodeled into compact bone on the outside, spongy bone in the middle. And here we see another view of that. Now, long bones form in a different way because long bones all start as hyaline cartilage, and bone replaces that cartilage from the inside out. It's the term endochondral ossification. Here's the whole process. We start with this little cartilage cell or cartilage model. Remember that cartilage has to be kept very thin. If it's not kept thin, the cells in the middle die because cartilage relies on diffusion to get its nutrients. So here you see these enlarging chondrocytes inside that matrix. Chondrocytes form the model. The matrix starts to calcify. The other thing that happens when cartilage is thicker, it tends to calcify like bone. So this will start to calcify. That further cements the fate of these guys in the middle. They're screwed because not only are they in the middle and relying on diffusion, now the calcium salts that are deposited outside the cartilage are also going to prevent nutrients from diffusing in. So when nutrients can't reach them anymore, they're just gonna die. And that triggers the rest of the process. When those cells die, blood vessels move in. So, dying cells out here, in there. Let me see that. This is called the primary ossification center. This is where the diaphysis begins to form. There you see them die. Now that blood vessel is going to punch through, and because it's growing through this collar bone out here, it's going to bring with it chondroclasts that break down that dead and dying cartilage, and osteoblasts to secrete bone in its place. So about 3 months in, this is what you got. Then osteoclasts dissolve the bone in the marrow cavity, hollowing it out, and that's going to be replaced with bone marrow. In the meantime, we're still adding new layers out here. Now, the same thing happens out at the end. It's thick enough, those cells die, it's calcifying out here. And we get these secondary ossification centers. Secondary ossification centers are at the epiphyses. And at birth, that's what you've got. Cartilage surrounding the secondary ossification center. Cartilage surrounding the secondary ossification center, and then bone here. So, in essence, you have 1, 2, 3 structures joined together by a cartilage plate on either end. This is sometimes called a metaphysis. This is the epiphyseal plate, growth plate. Some of the cartilage will stay there out here on the end to be the articular cartilage and the reduced friction in the joint. Long bone growth will end at puberty when this is replaced with bone. What happens? Well, you're familiar with the growth spurt of puberty. Those hormones kick in and you grow, and it makes the bone grow faster than the cartilage. Before, what you get is kind of an arms race. The bone is sort of chasing the cartilage. And as this cartilage grows and expands, it pushes the ends of the bone away, and then bone replaces it down here. At puberty, bone catches it, and all of that seals. So from childhood to adolescence, this is about what the bones would look like. Bone, cartilage, bone, cartilage, bone. After you're born, the bones will continue to grow through appositional growth. We're going to keep adding rings on the outside, and this is going to increase the diameter of the bones. But the interstitial growth of cartilage at the epiphyseal plate increases the length of the long bones. So that cartilage is pushing out. This cartilage right there, it's pushing out, and it pushes the epiphysis away from the diaphysis. This is really, really important. It's important that you understand that growth of the long bones in terms of length happens at the epiphysis. Bones get longer at the ends. Not in the middle, right? Cartilage grows here, and it pushes the epiphysis away from the diaphysis. Think about the way a tree grows. A tree, ground, there's a tree, happy trees, happy trees. It doesn't cartoon push up out of the ground. Like, you don't get a big freaking tree trunk just pushing its way up out of the ground, right? Right. If you've ever planted a tree or watched a tree, it starts with a little tiny stick. And that little tiny stick gets taller, and we're adding new rings around the outside. It keeps getting thicker. And as the tree gets taller, we add more branches at the top. The tree gets longer or taller at the end. Like today, if you went outside and you drove a nail in a tree, and it came back 10 years from now, where's that nail going to be? Put it inside of that trunk, it's being exactly the same place, just deeper in the tree as more rings are added around it. You do the same thing with the bone. In fact, we've done this for science. Baby cow, calf, whatever, born, put a nail in its femur, dead center in the femur, come back 10 years from now, and it's still in the same place in the bone, it's just more deeply embedded. Because bones get longer here. How is that triggered? Well, growth hormone does have a role in this, as does thyroid hormone and testosterone and estrogen to some degree. Bone deposit happens when bone is injured or added strength is needed. Anytime you damage the bone, it's going to grow to try to repair that. But the bones are also being reabsorbed. Osteoclasts are the cells that reabsorb or digest bones. They dissolve. They secrete an enzyme to break down collagen and an acid to break down that calcium salt. When it dissolves, it goes through the cell back into the blood. And that is the function of those osteoclasts. Those osteoclasts function to reabsorb the bone, not just to dissolve it for the hell of it, but to dissolve it and put it back into the bloodstream. Because again, 99% of the calcium in your body is stored in the bones. You might need to borrow some of that sometime. So what controls the remodeling of bone? Hormones. And the hormones here don't really care about your bones at all. What they care about is calcium. Because calcium is necessary for your nerves to work, your heart to work, your muscles to work, your blood to clot, your cells to divide, the release of neurotransmitters, the release of many hormones. It's essential. Let's use it. Let's find some terms here. Term hypercalcemia means elevated blood calcium. Symptoms of hypercalcemia. If you have too much blood calcium, the major symptom is lethargy. But you're always tired, just tired. It's really tired. Don't have any energy to do anything at all. You might see something like kidney stones. That sucks, right? Now let's talk about hypocalcemia. Hypocalcemia is not enough blood calcium. Your symptoms of hypocalcemia are going to be muscle spasm. That's going to suck. Your muscles are going to contract in places without your consent. Eventually, this will lead to laryngospasm, which is spasm of the muscles in your throat, and that, of course, will progress to your death. So, too much calcium in the blood, you're super tired. Too little calcium in the blood, you're super dead. As such, the hormones that we have here to control blood calcium are just there to make sure that your calcium levels don't go too low. The major hormone is parathyroid hormone. Parathyroid hormone's job is to raise your blood calcium. So if your blood calcium levels drop, remember that 99% of the calcium in your body is in the bones. So you go on the no calcium diet, you heard the calcium makes you fat. So your calcium levels begin to drop. Well then, parathyroid hormone is released by the parathyroid glands. Parathyroid hormone tells those osteoclasts to break down your bones and to throw the calcium back in the blood. We borrow that calcium from the bones, we put it in the blood, calcium levels come up. Are you losing bone density to this? Yes. Do you care? No, not really, because you're not dead. No, this is not, oh, as I described this, don't picture this as like a Hail Mary pass for your body. It's like, I don't want to die. This is a daily occurrence. Calcium levels, like other things, fluctuate with dynamic equilibrium. Calcium levels go down, you release parathyroid hormone, calcium levels come back up. You lose calcium throughout the day, they go back down, cycle starts over. It's a constant up and down thing. Calcium levels will vary between 9 and 11 milligrams per 100 milliliters. That's classic negative feedback. Now, this is crap. Calcitonin is stupid. Ignore this. Calcitonin is not a hormone of calcium homeostasis as far as we know. It has no use in the adult. It's more involved in bone development, so we're just ignoring all of this because it's not accurate. The other hormone that we care about here is vitamin D. Now, vitamin D, we call it a vitamin because we put it in food, but in reality, it's a hormone that you make. And vitamin D is going to raise blood calcium levels. And as you're aware, vitamin D helps you absorb, it allows you to absorb calcium from the small intestine. So that's all hormonal control. In addition to that whole hormone thing, we have just flat out physics. Wolff's law of bone tells us that bones grow in response to the force you place upon them. If you play tennis, the bones in your racket arm are thicker than the bones in your other arm. The bones in your right hand, if you're right-handed, are thicker than the bones in your left hand. Bones are thicker where they're most likely to buckle, trabeculate, form on those stress lines. And when we look at the skeleton, the shape of the skeleton is not pre-programmed in. It's not haphazard. It's created by muscles pulling and pushing and blood vessels growing through the bone. It responds to the force you place on it. If you ever see like the exercise equipment on the International Space Station, that is partially to keep the muscles from atrophying and partially to keep from losing bone mass. You ever seen WALL-E, right? Like they're floating around in space, and as they're coming back to Earth, he's like, you might have experienced some bone loss during the space flight, and it shows like the guy, like the perfect, whatever, walking around guy going to that giant fat guy sitting in the chair with no bones. That's legit. Because without gravity, you're just floating around in space, your bones don't have any stress on them. And the rule of tissues is if you don't use it, you lose it. And that includes bone. The bone will atrophy away. On the other side of that, if you put too much stress on the bone, it grows in that direction. You see bone spurs or osteophytes on the spine and in the heel because there's too much pressure put on the bone. So these big bony projections where muscles attach. Bone marrow makes blood. The red marrow makes blood. We find it in the head of the femur, the head of the humerus, diapolary of fat bones. In infants, it's all red marrow. Yellow marrow is fat. And it's in the diaphysis of adult bones. So now a word about bone marrow. Bone marrow, red bone marrow, makes blood. If you're not on the bone marrow donor list, it's a very easy thing to do. They send you a little test tube in the mail. You swab the inside of your mouth, you drop it in that test tube, you send it back to them. Congratulations, you're on the donor list. It's just like that paternity test you did for Maury Povich. Not the father. Except now you're actually helping the kid instead of just denying it. Here's the thing with bone marrow. The bone marrow donor bank, I don't even know what it's called. They report that about half of the people who match for donation, so they call you up and they're like, hey, you send in your test tube, you match with a kid that needs bone marrow transplant. About half of those people at that point back out. They're like, wait, you want to do that on a Tuesday? Yeah, I'm out. I got stuff. Forever. The reason for that is a misconception of how that process works. Bone marrow donation can be either direct harvesting of the marrow from generally the proximal epiphysis of the femur, or it can be harvesting stem cells from the blood. If it's harvesting stem cells from the blood, they just take blood from you. It's just like giving blood. If they harvest bone marrow directly from the bone, people freak out. They're like, that's a giant needle. They picture them like drilling this big ass hole in your hip and sucking out bone marrow with a straw. That's not how that works. You need to remember that bone is both really hard and really flexible. I lost that slide somewhere and I apologize. You can put a needle in the bone like in any other tissue. In fact, you will do so at some point. You will start what is called an interosseous line. An interosseous line is an IV in the bone. Right? You got a tiny little infant, can't get an IV in them, put it in the bone, in the tibial tuberosity. You got to drill a hole, just push the needle in. It's flexible. And this is the same thing. Now they're going to give you a local or whatever so it doesn't hurt when they stab you with this needle in the hip. They're going to pull out bone marrow. What's going to happen to you? Nothing is going to happen. You're going to be fine. And you might save somebody. And the chances of you being a match for anyone are not great. I say this. I've been on the donor list since '98, never matched. I gave this whole spiel to a class a few semesters ago. And like the next semester, this girl came up to me and she's like, you guilted me into getting on the bone marrow donor list. And then after I did the next week, they called me and they wanted me to go donate bone marrow. I'm like, did you do it? And she's like, well, I could not do it. Right after the whole guilt trip thing. So they paid for her to fly to wherever and put her up for however long and took bone marrow from her hip. And she's like, but it's fine. It didn't hurt. She had no effects from it. They gave her a local. They took the bone marrow. She hung out for a few days, and then they flew her home. And none of it was out of pocket for her. Didn't cost her anything other than bone marrow. So you should do that and feel better about yourself. Now, bones are really predictable in terms of their development. So much so that we can tell the age of a developing baby by the x-rays or sonograms, right? If you've ever had a kid, they measure like head circumference. Like, your baby's measuring 10 weeks or whatever. You want to mess with a neonatologist? Look super confused when they tell them that your baby's measuring 12 weeks. And then sit there and count. And you're like, wait a minute, that can't be right. Yeah. I told you I've got like 5 kids, right? By the 5th one, you try to amuse yourself. And that's my fun game to play with neonatologist. So here you see that's intramembranous ossification in the skull. You can see those skull bones forming. Endochondral ossification down here in the long bones. Here's a fetal x-ray. Don't do fetal x-rays. I don't know when they did this, but apparently it was a thing at some point. Don't. By the time you're about 25, all the bones are pretty much completely formed. By the time you're 40, it's going to start going down. Why? Hormones. We talked about parathyroid hormone, vitamin D. But also in play here are testosterone and estrogen. Where parathyroid hormone lets you borrow calcium from the bones, testosterone and estrogen help you pay it back. And with women at menopause, there's no more estrogen. So now you can't pay it back, but you keep borrowing it. Testosterone levels will go down with age, but not nearly as dramatically as estrogen levels. So we see this bone loss that occurs as people age. All right, so that will wrap things up for bones. Our next lecture here is joints. And then for this next exam, we'll have bones, joints, skin, and that will do that. So that's all for now. The next one coming up will be